Good afternoon, everyone. Welcome to today's Indian sessions. That is Indian Psychiatric Society South Zone and NIMHANS Digital Initiative for Academics and Nurturing Skills. Today, we have psychiatric care during pandemics, a panel discussion.
Good afternoon to everyone.
So, we discussed about patient services, etc. But one of the important areas which is currently running, most of them are shut down. OPD services are shut down, but inpatient care is running with the existing facilities available. One of the things which has to run all the time is emergency clinical services. So the next topic is running emergency care facility during this pandemic, and we have Dr. Senthil Kumar Reddy, who is a part of EPAC team here at NIMHANS. Sir, can you tell us what are the administrative challenges of running a psychiatric emergency care facility, and how have we dealt with those challenges?
Yeah, that's a very pertinent question, Chetan, and I think that's something that probably most attendees here would be also trying to work out. I would imagine it would pertain on an individual case-by-case basis, but for our organization, the nature of the fact that we had around 20-22 odd emergency psychiatry beds in what we call the short stay ward, which is the designated emergency psychiatry unit, we had to work out, patient care pathways in the context of the pandemic that would allow us to ensure that we screen people as per the COVID ICMR, COVID protocols and screening guidelines. Make sure that we could segregate such individuals from the rest of the psychiatric emergencies. So identify who were probably having, COVID 3 or below scores. So they were sort of, it was probably unclear. So there was a patient care, pathway flowchart that we had to create. We had to also restructure the entire layout of the emergency psychiatry service so that we could physically demarcate zones that would attend to these people who were not essentially COVID highly suspected, but had some index based on the fact that they had some non-specific signs that they could be potentially COVID. We also, from a structural standpoint, we set up one zone, which is the ground floor, which is a primary area, wherein there was a triage area where people would be screened, despite having been screened at the first level, had the enhanced casualty where all emergencies are expected to have their contact, and then be diverted to, say, neurology, neurosurgery, or psychiatry services. After that would be completed, and only if they had a score less than 3 or below would they be sent to the psychiatry short stay if it was a psychiatry emergency, and a token issued to the family member, and they could only enter the psychiatric short stay or the psychiatric emergency if the token was present with them, stating that they had been screened at our primary contact point at NIMHANS. We would again redo another screening for them at the triage. So the triage area was where the screening would be done, and if anyone scored 3 or below, then they would be attended to there and worked out as to what the nature of the psychiatric emergency was. If they scored more than 3, they would actually be redirected back to the Rajiv Gandhi Institute of Chest Diseases, which is a designated COVID hospital for Bangalore. And if they did not score at all, there was a physically demarcated specific area for attending to those emergencies that were, psychiatric emergencies that did not pick up, have any risk factors that were associated with the potential COVID infection. So, having to designate not just the physical, the challenge was not about just physically demarcating these spaces, but also making a pathway that would be smooth, would ensure that there is no overlaps or minimize the likelihood of the overlaps between these two groups of people, and also redesignate the entire human resources that are available for running the psychiatric emergency service. So we had to ensure that there was a separate team available that was attending to the patients who had some non-specific signs that could be suggestive of COVID, infection, but not necessarily confirmed. And all those staff members, ranging from the doctors to the nursing staff and all the other additional support paramedical staff, had to be sort of familiarized with all the PPE, and all the hand hygiene and other protective measures that needed to be that they needed to take. We had to ensure that minimum level of gear that could be, that was available to us could be used in an appropriate manner and in a safe manner, and that if all the staff were, safe. We had to conduct regular training for everybody in the department to make sure of all cadres, as the residents, the senior residents, the MD trainees, as well as the faculty. We also did the training for the nursing staff. I'm sure Dr. Sujendra will talk about that much more in detail. But to say that all were trained, in the, all the safety precautions that needed to be taken in the context of the COVID infection. One of the things that, the patient care pathways were where we found challenging. We had to redistribute, even within the both sides of, whether they were, suspected vis-a-vis, no risk of suspicion or no context of suspicion. We had to space out people, have adequate space, between each of the beds. So we had to clear out the existing, other areas of specialized care that we had available in terms of the intensive care and a high dependency unit. So we had to relocate all these areas again, given that this would be the only functional part of the psychiatry service that would be available after the lockdown that was there. So hopefully I've covered most areas. Chetan, is there anything additionally that I may have overlooked or you would like to know a little bit more about?
No, so that would be it. And we'd like to ask who commonly seek emergency care during this pandemic? Who sought in the past 2-3 weeks?
Yeah, so we actually have this, so that's a very, very important and pertinent question. And I think, it was the number of emergencies, as Dr. Muralidhar, the Deputy Medical Superintendent, just mentioned. We anticipated that we do continue to anticipate that the emergencies are likely to go up as the days of the lockdown go by. The nature of emergencies might change over this period of time. Initially, we anticipated that the majority of people would be probably people in substance withdrawal, and that was indeed the case. So probably, in the first few days, the range of substance withdrawals was from anywhere between 40 to 60% of the load. In fact, even greater at 75% of the load for the first 4 to 5 days after the lockdown. After that, the number of substance-related withdrawals and emergencies started to go down, as would be anticipated, because that is the crucial window period for developing alcohol-related withdrawal, at least alcohol-related withdrawal, which is the most common diagnosis that we saw in complex withdrawals that we're talking about, both simple and complex, has petered off in the last few days. So initially, wherein we saw people ranging, like I mentioned, from the total number of cases have pretty much remained the same. So we have not actually increased in our numbers as of now. This is again partly due to the fact that that the hospital is quite difficult to access in the period of the lockdown, given that whole cities are locked down as well, and we're a tertiary center, so we receive emergencies from across the state, which is probably not happening at the moment. The next most frequently encountered next two sets of disorders are obviously the acute psychosis and psychiatric or non-affective psychosis that we had encountered, as well as affective disorders, which were in more or less the same distribution. And in the recent few days, those numbers have increased. So the first few days, we had predominantly substance-related withdrawals that were presenting as a majority load to the emergency psychiatry service. And the preceding few days, we've had actually probably an equitable distribution of both affective, disorders and non-affective disorders presenting as emergencies. So just to give you an example, out of the total, probably, 25, not 25, probably around 23 odd cases that came 2-3 days ago. 13 belong to the psychotic spectrum, 10 belong to the affective spectrum, and another 4 were from the substance-related spectrum. So we're talking about 27 emergencies that presented on that day, and that was the profile that we had.
Mm.
We also we've had sporadically in the initial few days quite a few people presenting with anxiety spectrum or anxiety disorders as well. But that subsided apart from a small minority group of people who had organic issues or organic basis for their presentations.
I think we can also expect a lot of surge in people who are seeking emergency care in the coming days after the lockdown is lifted up. I think once the OPD also starts, many people can also be probably managed in a OPD setup. So Dr. Kasturi has asked a question that the challenges we face in a private medical college with psychiatric patients, quarantine patients, and COVID patients. So there are very few faculty present. So how to manage at such situations?
So, in a center that obviously attends to the entire spectrum. So if I'm not mistaken, Dr. Kasturi, from what I can understand, and that's quite an important point, is that you're talking about a hospital that has a designated area for caring for COVID patients. They also are concurrently running psychiatric services, and there are limited human resources that are available from a point of from the psychiatric perspective. Is that correct? And if so, what essentially is the backbone of the emergency psychiatry services at NIMHANS also predominantly constitutes the residents, both the junior residents and the senior residents, who are actually the primary staff with the psychiatric nursing staff, who are the ones that are, who are attending to all these emergencies. What we have done, at least in our setting, is we have sort of split the duty times to reduce the demand and the likelihood of exposure for all individuals involved in provision of care. So we've reduced the duty time and the duty hours, which is feasible in the context of the number of people and human resources that you have. So that's one way to address such a problem. The other way is also to ensure that you can, provide, have very clear understanding and clarity from the inputs from the few consultants that are present as to what sort of psychiatric issues or emergencies would be attended to in an emergency setting. What are the ones that have to be triaged and probably referred for, support locally. So if you're, there are a lot of states, for example, at least in the state of Karnataka, all the districts have a district mental health program. So the NIMHANS has actually set up, strategies, or has formulated strategies wherein all patients who've been seeking services for ongoing care at NIMHANS, actually receive communication of the fact that they can actually seek all their necessary medications that need to be continued from a local district mental health setting, which could be housed in the GH or the most nearby setting, and the teams there, the DMHP teams, could provide these medications to them free of cost, thereby ensuring that the patients don't have to travel. And making sure that their availability and access to medications is easy, and that limits the likelihood of recurrences and resurgence of mental illnesses over the period of the lockdown.
I think, so if I can add on to that, there are, if there is only one psychiatrist available in the hospital, then obviously it would be a bit difficult. But if there are more psychiatrists available in the hospital, including residents, what can also be done is to either divide the staff into half or one third. So if there is, say, for example, one third of the staff working, so if they contract COVID or if they have to go into quarantine, then they can be housed in the hospital itself in a separate ward, and rest of the people can take over. Usually, the quarantining is for 15 days. So if there are three groups who are seeing on weekly basis, so one group sees goes on quarantine for 15 days. The other groups comes in the next week. Uh, for 2 weeks they'll go on quarantine. The third one will come. By the time the last one third finishes, the first one third which was on quarantine is ready to come back. So in that way, if there are at least three psychiatrists, that can be managed in that way. If there are two psychiatrists, then half and half can also be managed. 15 days or 1 week, one group works, and the next 15 days another group works. Probably in that way, adequately uh, uh, distributing the human resources would be essential at this time. Sir, when we speak about human resources, so how to ensure safety of medical personnel in emergency care facility?
Yeah, as was mentioned by Dr. Muralidhar, and I'll reinforce it, and I'm sure Dr. Sijendra subsequently would elaborate on it. But the idea is actually to inform and educate the most accurate information, the most up-to-date information. Clearly, all of us are in a scenario that none of us have encountered in person or have had, and such an event has not taken place a priori in the preceding, last few decades, that would allow us to draw lessons or, use those experiences in the current scenario. So everybody is learning as each day goes by. So I think what essentially we have ensured is that everybody gets trained in maintaining all the necessary precautions or taking all the necessary precautions across, the board, from the point of cleaner, from the point of the cleaning staff to the nursing staff to the paramedical staff to the doctors. We have also familiarized all the duty, all the at least the psychiatry residents, consultants, all of us. We've familiarized ourselves as to what is the nature of sanitization of the ward that needs to take place, the cleaning, etc., etc. What are the sorts of things that is the frequency at which it needs to be done? Not that we would oversee any of this, that there are responsibilities that the nursing staff have, but nonetheless ensure that these are done. And if there is indeed a concern about the fact that some area is not being adequately sanitized, that the doctor can raise that, given that they are aware of how often they need to be done. The use of PPE versus other protective strategies would be something, again, that would be discussed in the next part of this panel discussion today. So I would not extend myself there, but essentially, even while conducting interviews in the emergency setting, we have encouraged all the residents to ensure that they maintain a minimum distance that is warranted. That would minimize the likelihood of them contracting an infection from either the patient or the family member or the attendee who has come with the patient to gather the necessary information. We have ensured that or encouraged all the duty teams to keep very clear-cut timeframes for management, stabilization, and ideally, if feasible, probably outpatient-based care. And in the last few weeks last few days, the numbers of inpatients that we have had, we've probably had around 25 or 20 to 25, probably around anywhere between 20 to 30 emergencies per day, psychiatric emergencies per day for the last 10 days, out of which we've only had 3 patients who've been admitted. So we're talking about a large proportion of patients actually being stabilized in 4 hours approximately, being advised the appropriate medications and being discharged directly from the emergency ward.
There are 3 more questions. Dr. Jishnu Bhattacharya has asked that is there any role of compulsory counseling clinic in every hospital, like fever clinic if possible by psychiatrists and psychologists during the pandemic?
Yeah, so we have a clinic that the clinic is being set up. It's actually so a lot of these things at least at NIMHANS are being, and that's a very important question because that's something that pertains to the larger community as well. So the 2-3 strategies that NIMHANS has taken up concurrently over and above the emergency, restructuring the emergency psychiatry services is actually setting up a helpline that's available nationwide in to everyone to address and clarify any concerns or queries that they have regarding the COVID infection vis-a-vis any other specific doubts, fears, apprehensions about the same. There is also, counseling that has been also set up through a group of the designated people at NIMHANS. Those services are being provided through volunteers, volunteer staff, trainees, etc., and that's been, again being delivered for various groups of people, including people with pre-existing mental health issues. Also trying to get them to link in with their local services is the strategies that we have adopted.
Sir, after the lockdown, as
Mhm.
psychiatrists, what challenges should we expect? Like, can we expect an acute surge in cases of say, depression, anxiety, PTSD, OCD, or something else? Also, considering the impact of economic slowdown due to the lockdown. Dr. Birwa Desai has asked this question.
Yeah. Okay. Look, it would be very difficult for me to conclusively answer that because it's the first time I'm encountering a lockdown myself. I think as most of us are. So, what are the and most parts of the world? So, I don't think this is something that would be an easy question to answer or predict as to what is likely to happen. Now, the 2-3 things that potentially are likely to occur is that we would experience, because whilst the lockdown is one stage of I think containment of the infection, or flattening the curve as to what they call it. The infection would remain in the community and continue to occur. So there is likely to be a proportion of persons who are potentially infected, who continue to present to hospital for other various reasons. Um, there is a likelihood that as a result of lockdown, people who have pre-existing psychiatric issues have not had access to ongoing medications, so they may experience recurrence or reemergence of their symptoms and present in crisis in the context of the same. The third are people who, as a result of all these extremes that they encounter as a result of the measures taken in terms of economic deprivation, etc., financial setbacks, vocational, occupational setbacks, are likely to also go into crisis and present in various ways, which could range from, depending on their vulnerability profiles, from affective syndromes to acute crisis-related issues, suicidality, etc. And so that would be something that we would need to be geared up to address, and be also cognizant or be aware that we can, that these would be the core areas and the domains that we would need to work on.
They've also asked, do you suggest different wards for all new admissions in psychiatry hospital, or are there any other options? Dr. Sunil Patel has asked this question.
Yeah, that's a very relevant question. So at least at NIMHANS, what we've done is, for all new admissions, we have like we did for the physical demarcation within the emergency ward itself. We physically demarcated across 2 floors. What has been done is there has been a demarcated zone for these COVID scores of 3 and less who are suspected, not likely confirmed. But they have non-specific signs. They can be admitted to that specific ward, which is physically separate from the rest of the wards. Whereas the other patients who do not have any such symptoms that could be potentially COVID-related can be admitted to the existing wards. As a part of even ensuring that we are adequately prepared to address this issue concurrently during the course of this period of time. Even before the lockdown measures had been put in place, we had preemptively, made sure that we reduce the number of patients who, could remain in hospital to an extent wherein only the essential ones were retained and most were discharged back to their residences, which is good. We still continue to have a certain percentage of inpatients who remain in hospital, not because that they warrant IP care, but they physically can't return back to their residences, which are in other parts of the country. And so, whilst they're well, they're in in an IP setting. So these people, because they've been here for some time, they're physically separate from the other side. So that would be, if feasible, yes, that would be something that should be encouraged till it's fairly clear that these individuals are not suffering from the infection, and then they can be transferred over to the common ward if need be.
Thank you, sir. Thank you very much for your time and the presentation.
You're welcome, Chetan. I appreciate being part of it. Thank you.
Thank you, sir. We also thank Linux Laboratories Chennai for their support through educational grant. Our YouTube channel is Nimans Indians. Kindly subscribe to the same